Hello, my name is Monica Smith, and I'm the Deputy Director for the Home Care Association of Florida. And I'd like to thank you for attending this event that is being offered in partnership with the Home Care Associations from the great states of Arizona, Nebraska, and Massachusetts. Before we get started, I have some housekeeping items to run through. We will be recording today's webinar, so if you'd like to recommend this program to one of your colleagues, we would appreciate that. It'll be available for purchase in the near future through the association you registered with and on our e-learning website at www.homecarelearn.com. Participant phone lines have been muted and will continue to be muted during the presentation to minimize background noise. However, for those of you who are listening through a phone line only, we ask for your help in avoiding any unexpected disruptions during the presentation by muting your phones now using your own phone's muting functions. Handouts were contained in the login instruction email you received from your association, but in case you cannot locate those handouts, you can also download them now from your GoToWebinar console located under the heading Handouts. Time has been scheduled to allow for questions and answers at the end of today's presentation. Please type your questions as you think of them in the question box area of your GoToWebinar console. We will be able to see the questions and we'll compile them throughout the presentation. We'll read them out loud for our presenter and respond to them verbally for everyone's benefit once she opens the session for questions. If you do not see the GoToWebinar console for the handouts and the question boxes I just mentioned, you can access these features from the menu at the top of your screen. Look for the orange box with the white arrow, which will also expand and collapse the console. With those announcements out of the way, I will officially kick off the webinar now as I start the recording. Welcome to today's presentation, which is part 1 of 6, Overview and Updates to Value-Based Purchasing, Preventing Unplanned Hospital Care, Emergency Room, Acute Hospitalization, and Discharge to Community. It is my pleasure to introduce the speaker. Lintwin is Principal and Founder of 5-Star Healthcare Consultants. Sharon has been in healthcare management administration for 30 years. She's been actor to Executive Director to Senior Managing Partner and Consultant. With that, over to you, Sharon.
Thanks, Monica. Welcome, everybody. Glad that you're able to join us for our series on value-based purchasing. I also appreciate that you allowed me to expand this from a 60-minute to a 90-minute session today. I thought that since we're doing a 6-part series that is specific on certain outcomes each session, it would be a good idea to do an overview and some updates to our value-based purchasing program. I don't know about you, but you know, we are just inundated with new things right now. I have been working furiously on building my COP classes, doing a lot of VBP classes, on and on. And so I'm sure that you all are having, you know, a difficult time keeping up with everything. You are the ones that are in the value-based purchasing pilot, and although I said that with some sarcasm, actually you are lucky, because think about when this gets spread to the country, what a whirlwind it will be, and so hard for those agencies. So by then, you guys will be pros at how to be in that top ranking of the outcomes. Especially those of you on this call. I always worry about all of the agencies that don't do sessions, because you know, they're the ones that you think, oh my, this is too hard to do on your own these days. I think it really does take a village to, you know, have a successful, viable home care agency these days. So I'm going to have a little overview of value-based purchasing. Also, I'm not sure that this applies to you, but of all of the areas that we have hitting us, value-based purchasing has, to me, been one of the most confusing ones as we, you know, read through it and how statistical it is. And so I'm just going to give you a very basic explanation of each of the areas that I know helped me. And I have to read it more than once, many times. So don't think that if you're not sure you understand what everything is as you are looking at your report, that's unusual. You really need to make sure you understand all the terminology. We'll obviously talk about CASPR and a little bit on the home health compare report, because what we're talking about today, basically they come from there. In addition to OASIS, we also have the complaint ER and hospitalization. We'll be talking about those. The outcomes, of course, that contribute to VBP, the 6 parts are going to hit a lot of those. Then, what best practice strategies can you use to enhance and increase those outcomes we talk about? Very important to have a strategy that you can plan, drill down to in order to improve outcomes. How can put this into QAPI? Well, if you're in outcomes without having a QAPI indicator, you may still be calling it a QI indicator. I've been calling it that for years. Same difference, the QAPI condition in the COPs for those of you who have been doing a good QI program, particularly if you're accredited, it's very similar. Well, these outcomes you need to make as indicators in your QAPI program, because then you can trend and monitor, do specific action items without waiting for reports to come out. And how to involve your staff. I am a key believer, and I have seen this work so often, that when you involve, engage, vest your staff and your agency in improving outcomes and tasks for monitoring, get them involved, that's when your outcomes increase. So that is a mini session of my philosophy. Next session, a refresher. What is VBP? Well, this value-based purchasing plan in 2000, it was shortly after OASIS began, was the year that our CASPR outcomes went into place. We started Home Health Compare. I admittedly, because it was May of 2003, as the executive director for Unity Health Services of the St. Market, a huge health system where I was over all the home-based departments. And we had a press release. We had a news conference of the colleges, and we had a lot of seniors there sitting at computers, as well as a lot of providers to explain about Home Health Compare and CASPR outcomes from OASIS. Now, because probably I was so involved at the beginning and through that pilot even, I had been teaching and reviewing CASPR outcomes and helping agencies improve outcomes since that time. The problem that I see over all my years as a consultant and a surveyor, because in that time, from 2004 to 2014, I was a surveyor as well. What I see in the back, people are that they really don't have a good understanding of the CASPR outcomes, what to do about through a QAPI program. So when we talk about value-based purchasing, when that came out in 2000, were, and now value-based purchasing is pay for performance. So those of you that have been around since 2003, you remember that very well. To me, that's what makes value-based purchasing make the most sense to me. Of course, it's all throughout the healthcare entities. It's to improve patient outcomes, of course, while lowering costs. That's the one key that's a little tricky as you improve outcomes, but we'll talk about strategies as we go through the week. It's required as part of the Affordable Care Act, ACA, and a part of the Institute for Health Improvement, IHI. Now, even though ACA was new under the last presidential administration, like I said, value-based purchasing was pay for performance. It's been around since 2003. It just morphed. Transitions home health from a fee-for-service payment model towards value-based purchasing. Now, of course, with PPS, that wasn't even supposed to be considered fee-for-service, but now they're taking it a step further. Obviously, it's rewarding agencies that provide better quality care per outcome. Well, I think Monica said 4 of you that are in the pilot are on the call today, and so there are 9, I believe, 9 in all. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 in all. And so not too many, but they got, you know, a state from each region. And I don't know, you were the poor guys that got selected. Okay, so it began January 1st, 2016. The catcher to that was that 2015 was your baseline year. And of course, we were also new at this time. But if you weren't really working on improving your outcomes in 2015, if you weren't making sure that your OASIS accuracy and consistency was excellent in 2015, you could be working with very skewed numbers as your baseline year. There's just no way around that, and that is part of the pilot. I should tell you that CMS is really doing a huge evaluation program of how this pilot is going. I was contacted by a person who's at a research company. I think it's L&M Research Development, and they were contracted by MedPAC, who is contracted as part of CMS, and they are doing a long, several-year study and evaluation of how this is going. So in that, you will be having contact from them at some point or other. They're talking to a lot of us consultants that teach it and work with agencies to increase outcomes. So, as I talk series of conference calls with them coming up, I will keep you informed at least of the parts I know. What I'm doing right now is talking to some of my clients that are in value-based purchasing pilot to see what, and I have a call. So he problems with just the program for sure. You guys are the really holler model for the incentive for the incentive payment, which that year will start in 2018. It's a 3%. It goes to 8% by 2022. So, even 3%, if you lose 3%, these days our margins are so tiny in home care that you have to pay attention to this. You have to improve your outcomes because that 3% is crucial. But every year going up 1%, and it's going to get harder and harder because everybody is working to improve their outcomes because that is their viability. And so it's very significant and could really change the shape of our home care agencies, our home care industry as it is today. Why is it so bad? Well, it's budget neutral. So it rewards improved quality and penalizes poor performance. So the guys at the top are getting the money from the guys at the bottom. Melinda, who's doing this series with me, and will be doing, I believe, the next 3 sessions. She's from HPS, Healthcare Provider Solutions. She did a great session at the HCAF Winter Warm-Up this January, and she has a sample result of 71 agencies. Obviously, she may be talking through that as she goes through, but the largest payment adjustment was minus 2.08%. The highest payment adjustment was only 0.03%, and only one agency in this sample of 71 had a positive payment adjustment. So those results actually, as Monica and Melinda and I talked about those, we said, uh-oh, we better have some help on how to improve outcome. Okay, so like I said, to me, still rather confusing, particularly when you read the final rule. So to me, these bullets on the next several pages are something that you can take away and refer to when you forget exactly what they are. I tried to drill it down to make it easy. The achievement threshold for each measure used in the model. It's calculated as the median of all home health agencies' performance on the specified quality measure during the baseline period of 2015. So for each outcome, this is the median of how we all did in 2015. The benchmarks calculated as the mean of the top decile of all agencies' performance on the specified quality measure during the baseline. For each measure, a home health agency with performance equal to or higher than the benchmark could receive the maximum of 10 points for achievement. For each measure, equal or greater than the achievement threshold but below the benchmark could receive 1 to 9 points for achievement. With performance less than achievement threshold, the receiver could receive 0 points. For me, that's the easiest way. If this is the first time you are reading this for a long time, since it first came out, you still are this. And so what you really will need to do with the information that I'm giving you is sit with your reports. You have those reports. I don't. They are specific for each agency and has a state. You need to have your report there, look at each measure, and then go back and say, oh, okay, yeah, that's what this means. So that you can be sure you know where these numbers are coming from, and you know that they are right in those reports. Improvement points. The agency can earn, and this to me is so critical, the improvement, because the baseline was 2015. Maybe you weren't working all this in 2015. Maybe you didn't worry about it a lot then. I know a lot of agencies weren't. So this improvement point potential is critical. So the agency could earn improvement points based on how much of its performance has improved performance during the baseline of 2015 for each measure. Improvement rate will be established that is this between the agency's 5-period score and the same to or higher. An agency could receive a score of 10 points. Here then is based nothing for each of those measures. If you don't submit, you don't get the 10 points. It is just getting into the portal and submitting it. So don't miss that, because you will be knocked down 10%, and you need every you can get, because out of our control. Things happen. And so the total is TP. That is the numeric 0 to awarded to each competing. Don't you love that they put competing in this? Agency based on performance and value-based purchasing. That's what this is now. Agencies are now competing against each other to say, hey, we are the highest quality and the lowest cost. Agencies for years have been using marketing to go over and say, oh, we provide the highest quality. Or I get so many calls, and this is over the 14 years that we've been in business, of startups constantly. And we always, there's never been a flag, new people ask us to call to say, can you help us with our startup? At least 5 a month. And the thing is that I always say, how are you going to get a constant referral flow? That's the biggest thing, because you have to maintain a census of 50 at all times to even think you're going to be financially viable. They all say to me, their first thing is, well, we're going to provide really high quality care. Well, everybody says that, but what does that specifically mean, and how can you prove it? Well, now not only can you prove it with our outcomes, but now we're in competition for each other. So those at the top, you better believe you guys are going to be out there marketing this. There's no question. Okay, CPS determined using the higher of the agency's achievement or improvement score for each measure. Using the higher of the two scores recognizes that you've made improvements, even if their measured performance score may still be lower when compared to others. So there again, improving. Don't ever say, okay, we're done with that one, we're doing good, we're not going to focus. Because if your 9 competitors are focused on that, guess what? Next year you will not be doing as well in that measure. Now, so that you understand, I had to do this because it was confusing to me always where they got these from. Well, in the final rule, you guys, because I have been working on VBP and COP classes 12 hours a day for the last several weeks, and I am not kidding, including weekends. I know that 338-page final rule by heart, believe me. Well, this, I'm sure you guys are taking care of patients and running operations. On page 146, it's table 24, and it shows every single measure is calculated. So, like example, improvement in ambulation. The numerator is the number of home health episodes where the value recorded on the document indicates less impairment in ambulation and discharge than it started for rock. No surprise there. They divide that, denominator, not dominator, is the number of home health episodes ending with a discharge. Of course, other than those that are covered by generic or measure-specific exclusions. So it's that simple, but each time I am looking at a certain outcome and how to help agencies improve, I like to have that information. Okay, so basically, we have, with the final update, 4 teachers and 3 new. The 3 process measures and the 3 new you should be able to knock out. So it is the other 14 that a lot of work has to go into. And where do they come from? 10 are from OASIS. I mean, it's always back to OASIS. So we're going to talk about that because, man, if you start working on improving your outcomes without knowing if you have OASIS accuracy and consistency, you will not have success in improving your outcomes. It's always about the OASIS. The claims are then a different time period than OASIS for hospital readmissions and ER visits, with and without admissions. That's what we're going to talk about today. And then 5 from the HCAP. Well, I have to be honest with you, most of the time as our health agencies improve their HCAPs in those areas, it's that added focus of how are we going to improve our outcomes that versus all of your to say, how are we dealing with our patients? That not only increases your outcomes, but it also leads to increased patient satisfaction. Now, I'm not saying you can ignore it. You can't. You have to look at those 5 measures and work on those at all. But so much of it goes hand in hand. 4 have been removed. So the outcome measures are improvement in pain, interfering with activity. I put the M items there for you just in case you don't know. But like I said, you guys are in the state where this is occurring, and you are probably more experts at it than me because you work with it every day. But it's the pain interfering with activity, dyspnea, bathing, bed transferring, ambulation, oral med management. And then discharge community is one of the ones I'm going to talk more specifically about today. And that one isn't on Home Health Compare. The rest are. You can see looking at these, well, I don't know, I can see looking at these because I have dealt with this so closely over the nation for so long. These are very important ones that they chose, and so many agencies do have a lot of problems with this. And we'll talk about in a little while, but I find often it's that the clinicians do not understand or know the Medicare intent. So we are going to look at that because that intent can make you score pain interfering with activity from no, there is none to yes, daily but not constantly. CMS does give a lot of caveats in order to say how to score these M items. And even if just one of your OASIS clinicians doesn't know that, or if your discharge OASIS is just too quick in jotting down any number, your outcomes will not improve and be sustained. The process measures are influenza immunization received, pneumococcal vaccine ever received, and drug education for all meds. The claim, and drug education for all meds, let me just say, the COPs are huge on that, of course, and it is so critical that you have a good drug regimen review and that it's documented all throughout your admission and your episodes, but your OASIS time points and how you answer this, very important. And then, of course, the claims-based outcomes. Note that they are not looking at the OASIS outcome for ERalization. They're looking at the claims. That's easier for them, of course, because especially for the post-acute facilities, they can start lining everything up. But it's a different time frame than it is on the outcomes. But, for the last probably 3-4 years, we've gotten both outcomes for our hospitalizations in ER plus the claims-based outcomes. So hopefully you're used to looking at those two variations. These are the two we're going to be talking about a lot. And then CAPS, it's still care of patients, communications between providers and patients, specific care issues, and then the two big money ones, overall rating of home health, willingness to recommend the agency. All right. Well, Barb put a fierce-looking little guy there. But how you're penalized, it's a self-penalization if you don't put these in, like I said before, very important. You have to get into the web portal, the VBP web portal. Only you guys can do it in your states where you're a pilot. And now the reporting on the home health agency is only required annually rather than quarterly. Makes much more sense. So they're going to require it after the 1st of April, and you have to get it in. Don't miss that. The final rule is now allowing 15 days versus 7 days for submitting the data following the end of the reporting period. Man, if I had Sharon's home care agency, I wouldn't even be waiting 7. So that is so critical to get in. Here's what they look at. The flu for your staff, flu vaccine for your staff, percentage of personnel that received or documented not received due to medical condition received elsewhere, declined, or unknown from October 1st to March 31st. Easy data to compile. You just have to get it from all your staff. And hopefully, you have almost 100%. So, but you're not rewarded. You don't get points about that. It's the reporting right now for the pilot. Herpes zoster, the shingles vaccination for home health agency patients. The number of Medicare beneficiaries over 60 that receive the shingles vaccine. So that has to be a new question that you always ask. Advanced care planning, patients over 18 with a plan or discussed and documented with the patient. So not too difficult, and just do them so you don't lose 10% of your TPS. The measures removed: prior functioning ADL, IADL, influenza vaccine data collection period, thank goodness, reason pneumococcal vaccine was not received, and care management types and sources of assistance. All right. So how do you improve your scores? Okay, key areas that I always focus on. Now, you guys are lucky because Melinda and I may have very different tips and very different strategies for you. And that's great because you can take the overall of what we're giving to you and get what works for your agency best. So what I really focus on is OASIS, accuracy, and consistency. A care management model. Case management. I've been teaching case management since, oh my gosh, when I was the director at Unity Health Services, I set up case management model, and I've been doing that with agencies forever. Well, now our COPs demand it. And guess what? It's a good thing. It helps improve patient care and your outcomes. Your CASPER outcomes report, your QAPI program, engaging all staff, and education. These are the things that I really focus on with agencies to get their outcomes up. So OASIS accuracy, if you don't have it, hey, you can work all you want on your outcomes and they're meaningless, they're skewed. So how do you ensure that you have OASIS accuracy? First, audit all of your clinicians completing OASIS time points. You have to do an audit to be able to see where you are. Trend those results. Identify if common problems or individuals. We have so many of our clients that are saying, can you give us trends? Because all we're doing is 6 things daily. And that's if all we're doing is we're not doing copy for them. We're just doing their coding and OASIS review. And so we're giving pages of things with OASIS. And the good thing lately is so many of our clients are saying, please trend them and help us figure out how to go forward. And that's what you have to do. You need to see, is it a common problem with everybody or is it specific individuals? So your education plan has to be very focused and tailored. If there's a common problem with 3 of the outcomes, educate all your clinicians on that, OASIS clinicians. If there are individuals that truly don't get it, then they need full education. So you have to take that kind of approach. However, you need to do a full OASIS class for all of your clinicians at least annually. I see so often directors of clinical services banging their heads against the wall saying, they don't get it. We taught them this 3 years ago. Why don't they get it? Well, it's a lot to get, and there's a lot that changes, and they have patients to take care of. And so this has to be done annually. You have to focus on the CMS OASIS Manual Chapter 3 intent and the guidelines, because like I said, those change how you answer, and it's for the better for us. So you want to be sure that you're going over that when you have OASIS training done. And then you're updating on all the CMS Q&As throughout the year, because a lot of times we get new guidance from those Q&As, and that's really not put anywhere and for the clinicians to see, be updated. Okay, then you audit again. This has to be ongoing audit frequency and the amount that you audit for your best performers. So after you audit, Nancy Nurse is a bang-up OASIS for clinician, not only on start of care and ROC, but also on discharge. Very important. So you're going to use Nancy to help audit, to help train. That is always a good thing to do, because then it's peer-to-peer. It's not, oh my God, she's telling us again to do this. She doesn't get it. Now it's one of your peers saying, oh yeah, this is what I do, and it works. OASIS consistency. Now, if all of your nurses do OASIS assessment and scoring one way, and all of your therapists do it another way, which can be very common, your outcomes are completely skewed. It's been shown with OASIS year after year that picture, that's a patient with blood pressure or blood sugars. And so we sit, we teach, we assess, we do a head-to-toe assessment. Talk. Well, therapists, get that patient up, get them taking that robe off, get them to sit on the toilet, see if they can do it, get them to walk down the steps going out their front door, and on and on. And so if you have that variance, what typically happens is that your nurses will score a patient too dependently, because they are being the doers, they are just asking the questions instead of seeing it. There are a lot of cases where patients don't want to say they're incontinent, they can't get to the toilet, etc., because they're afraid that they won't be able to stay in their home. They don't want to go in a nursing home, and so you have to see it. Then, on discharge, you have to have every clinician doing this as well. If you are not rating your discharge visits, pardon me, more heavily than a routine visit, if you're not weighting them as a start of care or a ROC, you really need to consider this. Yes, that will cost a little bit more in productivity, but we are competing in value-based purchasing now. And if you don't do a full comprehensive discharge OASIS, walking that patient around, having them take off their socks and shoes and put them back on and on and on, particularly focusing on value-based purchasing and star rating outcomes, you will have skewed outcomes. So this is very important. I love to do in-services where you get the agency together. I've done this on a state level before too, and that works, but you can do this in your own agency. Your star performers will play the patient, or you'll have somebody funny playing the patient. Always need somebody funny. And then your star performer nurse, star performer PT, OT, aide. ST, MSW, whatever. Typically for this in-service, I use SN, RN, PT, OT. That you set the conference room up like a house. You put those huge Post-its on the wall and draw a picture and put a chair that's for the sofa and steps and etc. And then you can get very creative. I've had some agencies where you go in the conference room, it does look like a house. There's a commode where the bathroom is, etc. Your staff come in. Now, the scenario is given about the referral on this patient. The RN goes in the home and does the assessment. She comes out, she reports to her care team therapy members that are taking care of Mrs. Jones with her about this visit and about Mrs. Jones. Now, they go to Mrs. Jones, and you will see everybody learns so much from this. Don't just have your OASIS clinicians in the room, have all of your staff, your field staff, including aides in the room, because you will get to see how a nurse, a PT, and OT is so different. We should be different. We have different disciplines, but we should all be doing a comprehensive assessment the same way. So when you do that, it's a real eye-opener on case management between the interdisciplinary team, how to do an OASIS M item to get the most accurate and consistent scores. And it's a fun in-service. So that's always what I recommend agencies to do. All right, so I talked some about care management. I'm going to kind of go through it quickly because then we'll get into the ER and the discharge community and hospitalization. But obviously, I am setting a foundation for what you will hear from me for every one of the outcomes I'm addressing. You need to have this foundation in order to improve any outcome. Then we'll go over the specifics on each outcome in the follow-up classes. Okay, so you know our new COP, I could recite it to you if you want right now by heart. Isn't that pitiful? It's case management. It has integrated care coordination. It's really focused on working together to improve the outcomes. So this helps us focus on outcomes, lines up with VBP. So if you don't have a case management team, or I've started to call it a care management team because that's COPs, it's a good idea to do so today. Geographic area, set up teams for each area. If you're a tiny agency, of course, you probably do not have enough clinicians to do this. But if you are, you know, a small to medium-sized agency and up, you can do this because you have more than one RN. You have an LPN. You have, you know, your PTs and OTs, et cetera. If you have two teams in a relatively small agency, well, you know that the OT and the aide and the ST and the MSW is going to cross over. That's fine. But you set up by setting up these teams. You really want to look then at continuity with this care management approach that helps increase outcomes because there's only a select people on this patient and they can work together to improve the outcomes. So, of course, you have to have backup. Your teams might be big enough that you're still going to have a lot of patients, people seeing the patient, because maybe you have a case manager, an LPN, and a PRN, RN as the nurses on one team. And then, for instance, a PT, PTA, an aide, an OT, a CODA. So, you know, it can get big just with that. But the lack of continuity can really destroy your chances at increasing patient outcomes. This care team maybe shares the patient caseload of 20 patients. They, of course, have to cross over sometime, but maybe those 20 are what they are taking care of. So Mrs. Jones, that team of me, the RN, Bob, the PT, Sally, the OT, Mary, the aide, we talked to each other about Mrs. Jones a lot. By EMR, by voicemail, by face-to-face, by all kinds of communication. Anytime you do any kind of communication face-to-face or by phone, documented credit. This team needs to focus on 2 to 3 outcomes that they are going to work together with Mrs. Jones over the course of the episode of care. And maybe over the course till discharge, because remember, our outcomes come from start of care or ROC to discharge. So if you're recerting, you're still, obviously you always update outcomes, but you may be working on this for your whole admission. Work together. When you do this, the team becomes goal-oriented. The employee satisfaction goes way up because it's more than just going visit to visit for a dressing change and a home exercise program. Plus, the patients see this team working with them. They buy in and the outcomes improve. Casper reports, just a very little bit, and then you have the slides to read them more thoroughly. Assign someone monthly to see if they've been updated. If they have been, now you need to dig into them. Very important that you have someone who understands how to analyze Casper reports to give you the best information that you can then incorporate into your QAPI program. You can't do all, so you start with the statistically significant, but you also look at every value-based program one, even if they aren't statistically significant for you. Okay, remember, from Casper, it's all what you come in from OASIS, what you put in for OASIS. Here are the reports that I always have agencies print out for me to review. The agency patient-related characteristics, it gives you tons of demographics about your agency. It also has the risk adjustment M items, very important. Those are your handicaps. Your risk-adjusted outcome report, that's where ER and hospital outcomes are, but remember for VBP, they're using the claims one that prints out with that as well. The potentially avoidable events for us for today, there's the adverse events that include reasons for ER visits. And then process measures. So in these are then your value-based purchasing ones as well. I always print out the 3-bar, that's most meaningful so you can see why, and the asterisk items, the statistically significant, you need to look at those. So in your potentially avoidable events, the ones related to ER visits, we have emergent care for falls, wound infections or deteriorator wound status, improper medication administration or medication side effects, hypo and hyperglycemia. Now, we're already knowing that they're looking at ER visits, so we have to look at these potentially avoidable events for ER very seriously. So anything statistically significant has to be addressed. In other words, addressed, they need to go as QAPI indicator right then. But you have to drill down. You have to see for every single QAPI indicator, every single outcome, is it a documentation issue? Is it a knowledge deficit issue? Or is it a care issue? So until you start doing audits and really drilling down in a QAPI indicator, a lot of times you don't know. Now, there are some times that I have been with agencies not too long ago. We were working on exactly this, the emergency care, where they were up over the national on 3 of the 4 things. And when it came down to it, oh boy, a lot of it was knowledge deficit and documentation, even in this area. Now, they did go into the ER, there's no question, but there were challenges. And so then you start digging into the chart and you see that, oh my, we could have prevented this. So you have to drill down. These, though, are not in real time. They are, your current period is only as current as October, and that goes back 12 months, and then, you know, the year before is your prior. So these are old. Now, that's not to say that isn't where your baseline came from, because the prior would be. But you need to do this in real time. So you need to have a process set up for any patient that goes to the ER for these reasons. you're going to audit that clinical record to see what you could have done as an agency to prevent it. Because you're going to take a twofold approach. First, the CASPR data, you use education to prevent that in the future, and then you do real-time audits of ER visits where you can have a more direct impact on what's happening now. Okay, so home health compare, I have a slide on here just for time's sake. I'm not going to get into this a lot. It is separated out into categories. You need to go into this frequently and see how you compare to the state and your competitors, and then the CASPR, you see the nation. And so they're both very important to look at, plus anybody in the world can look at this. And remember, they keep saying VBP is going to be public too in the future. So there's two links that, for star ratings and caps on the home health compare information, and then the actual link for the home health compare. So QAPI, we need to say this analysis of CASPR, you're going to put into a QAPI program. You're going to develop indicators from the value-based purchasing reports you have in front of you, your statistically significant outcomes from CASPR, your vulnerabilities identified on mock or real surveys, and your high volume, high risk, problem prone areas. I probably say that 20 times. I have been doing QI since I was in hospital, and I was a critical care director, and our healthcare corporation chose me to set up QI programs in the hospitals that they had across the country. It was called QA then, and it was this 10-step process that came out, and it was new to everyone. And so one thing from way back in 1990 probably to now that has never changed as much as the terminology has changed for a million times. High risk, high volume, problem prone is where you get your indicators to work on. Okay, so that took a lot of time, but of course so much that we talked about affects these three. Hospitalization in this first 60 days, ER without hospitalization, and discharge to community. Those three are preventing unplanned hospital care. They have common goals. You want to keep the home care patient in the home and or the community during the episode and at discharge. Okay, so what do we do to impact our outcomes? Well, we do what I had already talked about of the care management model. That's very important. And so what we're going to do then is say we are going to be each other's eyes and ears. I mean, that is a whole class in and of itself, but that is how it keeps it simple, is that you want to have your team working closely so that if Sally, the OT, is in with Mrs. Jones today, and me, the nurse, is not, but she notes that there's more leg edema and the patient's just a little more dyspneic. Well, I'm not there, but she is. That's perfect. She calls me, the nurse, right away and documents it in the clinical record so that the whole team can see, and then I make another visit, or I make a phone call, or I call the physician, so that we can stop before the patient has a CHF exacerbation and ends up in the hospital. This is a very successful manner of improving your outcomes in unplanned hospital care. So you want to identify your patients at risk for ER or hospitalization. It's very important to do that on admission, and then you have to update it throughout the admission. But on admission, you can take some simple things. You'll know if they have had past frequent ER visits and admissions. If they're a frequent flyer to you, well, they probably are at high risk. Non-compliance. huge reason for having to go in. Socioeconomic, psychosocial factors. You know, they're not able to afford their drugs, the house is just a disaster, and their family is not, you know, infection control is non-existent, etc. So this risk assessment can start before the care team even goes in on their initial visit. And so that you all have an idea that, okay, we know that Mrs. Jones is a high risk for going back into the ER or the hospital, or having to go into an inpatient facility when we discharge. So the plan has to be individualized per patient. Now, this is part of what I teach in case management model in so many of the classes. Front loading your visit is so important in home care, not just for nursing, but for all disciplines. Think about it. The first 7 to 14 days, especially following a hospitalization, I believe that's where the data is gathered, if we admit a patient to home care, those are the days that they're most likely to go back into the ER or hospital. Well, if none of us are talking to each other, if the nurse is going 1 week 9 and the PT is going 2 week 2 and the OT, whatever, but we're all going on the same day, there's not a lot of coverage of seeing that patient daily in at least those first 2 weeks. They haven't retained all the education. They probably aren't over all their symptoms. They haven't been taught on all their meds, and on and on. But, pardon me, if we front load our visit as a team, we're seeing that patient almost every day. So then we drop that frequency down, and that helps with our expenses, and it also is okay because now most of the teaching has been done. Now we have their symptoms under control to do. And so now we're dropping, every discipline drops the visits down. We're trying to make that patient more independent and stay in the home and be functional in the home. So as we go through the course of care, we can drop those visits down to 1 time a week. This can even be for PT and OT and aid. The aid, we want that patient to be getting more independent. If that is possible, and let's say the OT is in there and working on strategies to make that patient more independent, communicate that to the care team so that the aide can drop their visits down as well. Very important. So important to communicate with your on-call staff about high-risk patients. Now, a lot of ER visits and hospitalizations are after our agency shut. We are 24/7, but our offices are, 8 to 5. And so after hours, a lot of times that's when patients will go to the ER and maybe be hospitalized and maybe not be hospitalized. So, you know, the thing that I saw over all my years of managing home cares as well as being a surveyor and a consultant is that when you have a complaint, complaint survey, a lot of times that can be tracked down to an after-hours problem. Or if you just had somebody admitted and you look at that chart, you find things that we just didn't do good enough after hours. On-call is a huge part of what home care is. And honestly, weekends is a large part of what home care is. There are still too many agencies just doing the 8 to 5 Monday through Friday and have a very weak on-call and weekend response to patients. And the problem with that is that very often can end up with ER visits and hospitalization. So now think about it in that competition way. If you're one of those agencies that I talked about, now XYZ agency has coverage with clinicians on longer shifts, not just on call, or several on-call staff that are on for different reasons, different territories out of the care teams, have an escalation process. So in other words, if there is a challenge with a high-risk patient after hours that on-call nurse is called about, they need to contact a supervisor or whoever to discuss if a visit needs to be made. Not, as so often happens, a 5-minute phone call and says somebody will check on you the next day. Or I've even seen worse, and I've written deficiencies for worse, where that next day that was never communicated and the visit wasn't made till 4 o'clock. Well, that was too late. Nobody was home. So looking at your after hours, both every evening and night and weekend, I know more and more agencies are having weekend staff. Well, that is a good thing, because if you don't see a patient from Thursday to Tuesday, goodness, their chance of ER visits and hospitalization soars. So you really need to take a close look at this and not just say, we could never afford to do anything else. Well, a lot of these things are not that increased cost, because you're looking how it shifts your staffing overall, and the front loading, your visits are decreasing as you're going down, but overall, your ER visits and hospitalizations go down after hours. You have to provide additional training to on-call staff. Any new procedures and processes you put in place as you're looking at this, and you really need to get the staff to understand that the goal has to be to avoid ER visits and hospitalizations. Physician notification early and timely. That is the key very often to preventing ER visits. The thing is that agencies say to me all the time, well, you don't understand. We can't get our ER visits down because our doctors, when we call them, first thing they say is send them to the ER. Okay, so then what I say is, all right, well, when are you calling them? Okay, you're calling them when they've escalated more, they've exacerbated more, and the doc doesn't want to mess with it then. Well, what if you are instead notifying them early, as soon as there are the first changes seen in that patient? This is not just for the nurse. This is that care team. The patient's care team sees things like the patient's more fatigued when the OT is working with them. Did the patient cough frequently with the aide? Is the BP up when the PTA is with the patient? Is there more pain not relieved appropriately with current pain meds? Any new and worsening symptoms? Now, the OT is not going to call the doctor and say the patient's a little more fatigued today. What I'm talking about is this care team talks to each other. They tell each other that, ooh, I'm kind of seeing this and I'm kind of seeing that. Now, we already know this is a CHF high-risk patient in Mrs. Jones. So all of these things, we could say, uh-oh, are we at a point individually as these things are occurring that we better tell the doc? She's starting to exacerbate. The doc says, give her an extra dose of Lasix every day. It could be as simple as that. I've seen it happen over and over and over. But if you all don't talk together and you don't call the doctor timely, then of course when you call them when things are a lot worse, he's going to say go to the ER. Many, many times I review clinical records for a rehospitalization, whether it's that they go directly in for an unplanned hospitalization or an ER visit, and we see lots and lots of red flags for the weeks leading up to that hospital visit or admission. And so you need to do that. You really need to look at your clinical records when a patient goes into the ER or is hospitalized and say, what did we miss? Could we have called Dr. Smith earlier? Because here's what the PTA documented one day. So did we miss that? Did the care team not do anything with that? Because the PTA didn't tell anybody, and now there wasn't another visit made for 4 days. So those are examples I'm giving scenarios that happen. So look at your patients that go into the ER and are hospitalized and say, I'm going to look at those clinical records and see if, it's usually in the 2 to 3 weeks leading up to that admission, what could we have done better? You will have an objective QI indicator with an audit tool to do that. Now, how else do we keep the patient from going into the ER and either being admitted or not? Telehealth is very crucial. And I think that in today's world, with outcomes, improving the best patient outcomes with the lower cost, telehealth should be something that every agency, administrator, CEO, owner is saying we're going to start doing now. Now, first of all, you can start it today if you're a director of clinical services. I'm not even talking about having to go and get approval for big things. Telehealth on the phone is crucial. You want to keep up with your patients in between visits. You can't visit every patient every day, but you sure as heck could give them a phone call. And so that's the first way I'm talking that costs you nothing but having a, staff make these calls. Well, that may be a little bit of an expense, but overall it's huge in improving your outcomes and keeping your patients out of the ER and hospital. They are crucial for patient compliance. You know how often that the patients all gung-ho and then you go see them the next week and they kind of dropped off. Well, just for yourself, that's human nature. You can find out if there's any changes. It helps you maintain a great rapport, and you can identify more risks that you're going to share with the care team and maybe the physician. Now, well, I should have went to this slide because I have lots on the telephone calls before I'm telling you to buy anything. So you do it in between visit days. I would say you have somebody calling evening and weekends for the high-risk patients because we already know that's when they go in. You can have a script that you develop that is individualized by that risk or the disease so that we know for sure that when we assign somebody to call this evening, when she calls Mrs. Jones, she's not really knowing what to say. So just saying, how are you doing this evening? Miss Jones says, fine, I have no problems, and that's the end. Instead, we want a script that we go through when we call on the days between visits to say, specifically, is your shortness of breath worse when you're walking up the steps into the bathroom today? Patient-family communication to the agency. Every single visit, you have to tell the patient and the family and caregiver to call you before they go to the ER, unless, of course, for emergencies. Well, think about it. If now you're making phone calls in between visit days, you can remind them that all the time. Very important. And we'll get to it, but so often there are ER visits without hospitalization. Well, that meant that they weren't sick enough to go in the hospital, so they could have probably called you. Give them specifics about what kind of even minor changes you want to be called for. Example, Mrs. Jones has increased edema in her feet and ankles. But if you're making frequent phone calls, even if they forget to call you, you're going to find out because you're with them more frequently than just visiting them a couple times a week. And then, of course, you want to know from the family right away if the patient went into the ER or if they were hospitalized. Too many agencies don't find out, and they go knock on the door for days, and so you want to find that out as well. Now, if you can get, or if you have the telehealth units, I would recommend starting to use them on the high-risk patients that you're identifying for ER and hospitalization right away. You want to buy the peripherals. You want to customize them to your patient risk and or disease. Don't just get a regular monitor, you know, without a scale and a blood pressure and a pulse ox if you're trying to keep CHF patients out of the hospital, for example. Now, video conferencing is newer, but I have read a lot about that published over the last year, and many agencies are planning to use Skype or other video technology to speak with patients. That was in a survey conducted by, I believe, Home Care News, that I see that news email every day. For high-risk patients, that's great for wounds, CHF, COPD, CVAs. So just want to make sure you're ensuring HIPAA compliance. When I put Skype there, I just took that from what I read in articles. I have no idea about HIPAA compliance with that. I really am not. I have not dug into that at all. But then there are companies, you know, that I think the EMR companies that have that as well. Okay. Proper utilization of services is really key when you are saying, how do we keep that patient out of the hospital? You want to be able to really know that you are putting in an OT appropriately. An OT is an absolutely excellent way of increasing your patient outcomes. They work on those functional issues. An MSW, a high-risk patient that's living in their own home, an MSW is an invaluable visit or discipline, and they can really work on that discharging to community when able to keep the resources. What resources does that patient have to keep them at home? An aide is very low utilized in today's world, but your aides are with your patients a long time. They can really see the important issues. Then just be sure the aide communicates to all supervisors. The new COPs, that can be a therapist as well. But as far as these disciplines go, be sure to watch your utilization. And I talked about front loading before. There's some examples. Your patient education, of course, we talked about on-call. Med management, you know, we have to make sure every visit we're addressing medication management, effectiveness. If the meds are not effective, we need to call the physician. That is a very weak area in home care. Disease management, so that you can set up specific teaching plans for all the care teams. Now, at the end, I give you a link to a CMS web address that actually has very good tools in there. Many of them, you have to put your provider number in, so many of them I can't even get to until I'm working with an agency. But some you can see without doing that. The potentially avoidable events, specific frequently teaching, we talked about that. Good patient education tools that you discuss and give out frequently, not just here's the patient handbook and move on. So have flyers created that you take along the way. Get the magnets, have magazines. There's all those free magazines that you see in doctor's offices for each, you know, disease management type. Anything creative like that to keep it fresh, to educate that patient, caregiver, and family more. So, of course, we talked a lot about the high-risk patients and the care team to take action from the results of the patient education. As each person that's in the home is teaching a certain thing, that needs to be communicated with the team. Plus, you need to document your education. That is so weak in home care and often leads to deficiencies, and will definitely with our new COPs. So it's a great way in your EMR, set it up. Most of them have a spot where you can get information with a dedicated group of people. So that's where this care team that shares 20 patients would look every day. I talked about the long weekend gap. I talked about weekend staff or phone calls. be sure that you have more patient visits on Mondays. If you do have that weekend gap, that's a great way because you know they're going into the hospital then. Now, the discharge disposition is, kind of an odd one, but did they remain in the community without formal, with formal, non-institutional hospice, unknown, moved to a geographic or other unknown? Now, the thing is, if your agency can identify that you have a high rate of hospital admissions that are avoidable, then it helps improve this depending on when the admission is. What this factor is it looks at the number of episodes where the discharge indicates discharge to community as the numerator over the number of episodes where the number of episodes end in a discharge to inpatient facility, the denominator. So as an example, if your agency has 35 discharges to community and 7 that go to an inpatient facility, you're sending 5 times more patients to the community than to the hospital, which is what we want to do. So you can see how this ties in directly with how do we keep our patients from going in the hospital. Now, of course, there are always going to be reasons that, well, the patient's just not appropriate to live at home anymore, and we're working with them to get them into a facility. But, and that's why I said this one's a little odd, but that's how you can look at it. And so pretty much a lot of the action items you're taking to prevent ER visits and hospitalization are the same. Now, I'm not going to get into it, but I do have it down there that this IMPACT Act is really looking at following 60 days from home health discharge if they were admitted. But that's going to all tie together someday, we're told, but just as an FYI for the future. I said if you have an ER visit without hospitalization, that tells me a lot of times maybe that ER visit could have been prevented by home health. A best practice is definitely to have a nursing visit prior to the patient's ER visit. Obviously, I'm not talking about for emergencies that they need to go right away. I already talked about, I jumped ahead of my slides, about auditing all ER visits in real time. Here's right there, those bullet points are indicators you can put into a QAPI audit tool. Well, selecting indicators I've done all along the way, but now I have a lot of information that really shows you details that you can take back to your agency to start using as examples to develop your tools. You have to know those VBP reports from your state. You know that one that Melinda showed was not that good. Statistically significant, focus on STAR and VBP and statistically significant. There's example of clinical items and of multidisciplinary items. And then outside of that, IV services is a high-risk and problem-prone area. Maybe it's a high-volume area for you. So definitely, if you're doing IVs, that should be a QI indicator, and that is a frequent reason to go into the ER. You want to have a task force of stakeholders. You want to set up for these outcomes that you have selected. Okay, now I want every discipline. I want people very involved in this. I want us to get into a room and I want us to brainstorm. What are we going to do to improve this? You will be so happy to see how invested that whole group of staff get when they are doing this. They need to be involved. They don't just need to be told what to do. So these kind of stakeholder task forces to put together what we're going to focus on as far as OASIS teaching, OASIS consistency, the care management model, and then the individual drill down in the QI audit tool. Very important. You may have to review, I won't say may, you need to review with your staff how to review clinical records. I have found that that's very important to do before assigning a bunch of field staff that have never done clinical record reviews before what to review. So have a very focused audit tool that you develop and then teach them how to review the chart to look at these things. So you have to assess your agency performance levels. You're going to continue to monitor. We need to drill down as far as we can. You can drill down to disease types, to care teams, to disciplines, to a person. Very important to do in order to focus most of your time where it needs to be by drilling down to see each problem. This isn't busy work. You have to do this. Now, like I said at the beginning, I love that lady at the bottom, and I know that a lot of you feel like that. But the definition of insanity is doing the same thing over and over again and expecting a different result. You're not going to get anywhere. So if you're not improving, you need to say, why are we not improving? In other words, you go back to the drawing board. You don't keep trying the same thing. Audit over and over and over again. You need to review that QAPI indicator. Maybe it's not right on track. Maybe you're missing the point, and it is an OASIS issue. It's not a care issue. Is it specific to CHF? Is it specific to my team? So now you get together, brainstorm, you develop a whole new plan because it's not working. All right, so now, very quickly, I'm going to show you the examples that I have in here for you to take back so it becomes more real for you to put your things together. So ER visit for falls with injury, the QAPI coordinator or designee will audit 100% of records with ER visits for falls with injury per quarter to the audit criteria with an expected threshold of 90%. So the audit tool, you want to see a 90%. Now, the potentially avoidable event, ER for falls with injury, will be below. Well, you need to get that way below. You know, we want to get it to 0. But if that's not realistic, then you get it to what is below the benchmark. Here are some criteria that you can use in an audit tool for falls with injury. I always like to put my money question, my big money question, as the last one, and that does not get incorporated into a score as you're totaling simply because it's more subjective by the reviewer. But was there anything the agency could have done to prevent the fall? That question I put in everything. So now I'm looking at the last 3 weeks before they went in, and I saw that the care team was not telling Sally, the OT, that the patient was having her anxiety attacks more frequently. They did not call the physician to see what he wanted to do with medication on that because she's a frequent flyer and always has this. Then Sally goes in to do an OT eval. The patient had an Una boot. She was just walking her into the bathroom to the shower to see if the patient will be able to get into the shower. As the OT and the patient were doing this, the patient had a terrible anxiety, yanked on Sally the OT, not her real name, and pretty much they both fell into the shower. And the patient had a fractured hip. Well, we did a root cause analysis, and we found out that the communication was horrible between the team and between the physician and many more things. So that's what you want to look at the end and say, gosh, what could we have done to do better? All right. Here's an example, reviewing 100% of patients going to the ER without hospitalization quarterly to see what we could have done. Here's an example of an audit tool. Now here's a real drill down. In the agency patient characteristics report from Casper, it says that you have patients going to the ER for other respiratory and uncontrolled pain at a much higher level than your prior and national. Something's wrong there. And so in that case, you need to set up a QAPI indicator to drill down and see what the heck is the reason for this. So we want to see if this is true, why it's true, what we could have done to prevent it. So in this case, you'd have 2 criteria again, and I always put the goal the threshold, whatever you call it, of your audit tools to be at 90% compliance. The CASPER data, the outcome data is different because now we want to decrease this, but we're not going to be so unrealistic to say we're going to decrease it so quick that it's going to come down to 0 or to national, but that's what we're going to work on. So I'm out of time, so here is the respiratory tool sample, the pain tool sample that we used. Rehospitalizations, I always say you should be and I've said this for years and years, you need to audit 100% of your patients that went back in the hospital or the ER while they're on care with you. So there's some examples that you can take back and start drilling down. Don't allow yourself to be so caught up in all the whirlwind of changes we have. Million new acronyms by the day. It comes down to what we know. It comes down to your OASIS. How is it scored? How is your assessment scored? What do your patients think about you? It's not new. So whenever you start to get freaked, the deer in the headlights, think of that. We've been doing this for years. Your new part, you really need to understand those VBP reports and start drilling down to where you are so you can make sure your efforts are focused where they need to be. Well, your QAPI program, you heard how much I've talked about that. If you're accredited, you know all that and should be doing it or you're not compliant. But if you're not accredited and you haven't been doing too much at all with the QAPI program, well, guess what? You have to now. July 13th, don't think that QAPI is postponed till July 18th. Too many agencies think that. You have to have your program, your indicators, you start collecting your data. The PIP projects, the performance improvement projects, they're giving you a year to collect data. However, you have to increase your outcomes now. So you're going to be taking these into more projects like I had explained in some as examples long before then. Educate and involve your clinicians. That is what gets your outcomes up. When agencies say, yes, we're going to involve everybody, we're going to get them vested. Yes, it costs a little bit of money to have the staff in the office for brainstorming meetings, for a few clinical record reviews, things like that, but oh my, in the long run, you will be the financially viable agency, and you'll be in the top box. Here are the links that I told you about where I found a lot of good information. So you can check those out. It's mostly from HHQI that has a lot of tools you may use. Okay, so I am stopping 1 minute before the end of my time. You can see how much information this is. My next 2 classes that I do at the end of the series are 60 minutes long. They won't be near this in detail. They will just focus on the outcomes that I will be talking about. And Melinda will be focused on the outcomes she will be talking about. So this one is kind of a framework for how we're going to go forward and how you can set up in your agency to be successful with VBP. So exactly at 12:30, Monica, I can turn it over to you for questions.